Welcome, everybody, to the Texas Primary Care Consortium's monthly Monday Primary Care Talks. My name is Nishi Singhal. I am the program officer with the consortium. These monthly Monday Primary Care Talks, we are dedicated to interviewing speakers from across Texas covering a wide range of primary care topics. Each month, we bring you informative episodes as your go-to resource on all things primary care. This month, we are no different, and we are bringing you an interview with Chris Skisak. Chris Skisak is the Executive Director of the Houston Business Coalition on Health. The coalition is a multi-stakeholder but employer-centric organization focused on improving the cost, quality, and consumer experience in healthcare delivery. Chris is an advocate for value-based healthcare delivery systems. He writes and speaks nationally to advance this agenda. Chris is originally from Chicago, and he's received his master's in science and PhD from the University of Texas School of Public Health. Let's go to the show. Thank you so much, Chris, for joining us today. I would love for you to tell us a bit more about yourself and how your work impacts our primary care system here in Texas.
Sure. Thank you, Nishi. Well, again, Chris Skisak. I am the executive director of two organizations. One is the Houston Business Coalition on Health. The other is Texas Employers for Affordable Health Care. A bit about my background, health scientist by training, received both my master's and my doctorate from the UT School of Public Health, and wound up working in the commercial sector for large energy companies for about 25 years. I have been the executive director of HBCH for 12 years now. Our mission is to improve the cost, quality, and consumer experience for the employer purchaser of healthcare services through their benefits plan. That's one organization. Texas Employers for Affordable Healthcare is a legislative advocacy organization, a 501c4, HBCH, a 501c3. We work at the state legislative level to get legislation passed that will create a more competitive and employer-friendly marketplace. Last but not least, I am on the Board of Governors for the National Alliance of Healthcare Purchaser Coalitions. That is an organization of approximately 45 coalitions around the country that voluntarily joined the National Alliance, and collectively we represent about 60 million employer-sponsored lives. Interesting to say, though, that my familiarity with the value of primary care has been influenced by all of these organizations. I have been familiar with the concept of advanced primary care for years now, and we through these and the National Alliance are constantly promoting its value. As a matter of fact, through HBCH, there's enough interest that we want to have next year a primary care users groups, advanced primary care, to keep promoting this because we believe it's such a strong foundation. So that's a little bit about me and the overlay of primary care. How would you like me to go into this at the next level, Nishi?
Well, so you talked about advanced primary care, and I would love to hear in your own words, how do you really define what advanced primary care is?
That's an excellent question. I think right now, if one would say if you've met one APC group, you've met one APC group, and they're all a little bit different. The National Alliance actually put out a group of tenets for what primary care can be. And some of our sister coalitions that I'll mention in a minute are really focused on this in a huge way, as we are in Houston. But some of those tenets for primary care is certainly enhanced access for patients. Think 24/7 coverage. Um, think same day, next day appointments. It's tough to get the value out of primary care when you're told to come back 3, 4 weeks later for something that isn't an emergency. It's probably not a good fit. It's more time with patients. It's difficult in a fee-for-service delivery model for the patient and the physician to get the maximum value when both feel rushed. There needs to be that more time. To do that, one might think you need realigned payment methods, another tenet. We through HBCH have been working on what we call a smart network. It is a capitated primary care model. We believe you have to have a capitated primary care model, and perhaps at risk, if not initially, then down the line. So again, a capitated primary care delivery model, uh, allowing more time with patients, more access with patients. Another tenet of advanced primary care is that it is integrated with behavioral health. Behavioral health is huge for our members, and of course, there's a real shortage. Um, we believe that behavioral health has to be an integral component of this, perhaps starting at least with measurement-based care um, uh, in this capitated model. It's I know some primary care physicians are hesitant to do this because, okay, if we screen and we find something, what do we do? How do we refer? How do we treat? Well, I won't go into detail here because this is a big um, uh, part of the TPCC. I know that collaborative care is a model that works. There's 69 published studies on it on its value. We are big proponents of the collaborative care model for behavioral health. Uh, Perhaps the biggest part of of not the biggest, but a major component of advanced primary care is effective referral management. Uh, to us, to the coalitions, this is critical. There is any self-funded employer or fully insured employer, their largest cost is hospital inpatient and outpatient services. Um, we believe that it is critical to have effective referral management. And when I say that, quality into value. And there's a lot of different ways that one can tap into that. Several of our employer members use vendors. There are several of them, Accolade, Quantum Health, Included Health. There are a lot of different vendors out there that, through a variety of means, assess value in terms of price and quality. Several of our members who are working with advanced primary care groups are requiring that they refer to these or using these tools, have access to them for effective referral management. But the core foundation of advanced primary care is that through effective primary care, you have the prevention aspect. You have the uh, uh, management, high quality management of chronic conditions so that they don't even need to be referred to specialists. But once you have this model set up, there will be referrals to specialists, and it's for again primarily inpatient and outpatient care for that provider. So we believe that the promise of APC is that it improves and increases the health, patient engagement, satisfaction, provides personalized holistic care. It reduces unnecessary care and referrals, um, urgent care, ER, hospitalizations. So in essence, finding a way to reduce total cost of care. When I talk to my employers, and this is mine and any coalition leader, they talk to their employers and what is your biggest challenge in healthcare? It's not I need more primary care. It's I need to lower my total cost of care. So somehow primary care and total cost of care have to be related, measured, and understood. Does that
Yeah,
help?
and it does. And I'm curious, is there some sort of education that then needs to be done with these employer groups that, for their goals of lowering their costs, maybe even improving quality of their employees, it's actually primary care, investing more in primary care for them would actually help solve some of those problems? Is there like a level setting that happens with them?
It's a good question. We have held several educational sessions on advanced primary care. We work with a large core of employers through our smart network. They believe in it, they want it, but these are skeptical, risk aversive organizations when it comes to healthcare. They're looking for tools. We would say that the legacy stakeholders in this, the hospital systems, the health plans, the benefits consultants, um, that these answers will not come from them. The answers will come internally through their education and acting upon that information. So as again, we have put out a lot of information on this. Um, I don't know if this is the time to. It's not only education of the employers; it's the education of the physicians. And I'll give you an example. One of the largest coalitions in terms of big big employers, jumbo employers in the country. It's the Purchaser Business Group on Health. They are into this in a big way. One of the things that they wound up producing is a common measure set, and I could provide this reference to it. And it's things that primary care organizations should be looking at to demonstrate the value of primary care. And the common measure set consists of different NQF type of measures in health outcomes and prevention, and patient reported outcomes, patient safety, patient experience, and high value care. There are, again, metrics in here that are used. I won't go through the whole list, but I know with our smart network, we were insisting that the primary care groups provide measures for these, and they're not complicated things. Asthma medication ratio, colorectal cancer screening, controlling high blood pressure, diabetes A1C, immunizations, things of this sort. Um, uh, Mental health, by the way, is looking at this. As an example, high value care, emergency department visits, total cost of care. Again, there's these metrics. Similarly, just this summer, PBGH put out an RFI. They want to partner in select markets with primary care groups to see their employees. And again, in the Houston market, these are companies like Lowe's, Home Depot, Walmart, Boeing. Boeing is perhaps a national leader in this. First and foremost, they are setting the tone here. Uh, but in this RFI, there's opportunities to, again, primarily as a group, to be vetted, if you will, by them to see their organizations, who they want to work with. So there's several sections of this, and we don't have time to go into this, but the sections are whole person health and well-being, health outcomes, behavioral health integration, as I've mentioned, health equity, payment structure, and performance-based payment. Those are examples. That's mandatory. Others who may not meet certain APC clinical measures, I think I've shared some of those with you, are employee patient activation and engagement, coordinated care, that's critical, risk stratification and care management, access, informed referrals, as I mentioned, and health information technology and data sharing. So again, uh, these are our activities that are going on, that we hope will drive, um, more primary care utilization by employers. I can't overstate the importance that we believe, and I think coalitions in general, on primary care. The problem is primary care right now is accessed through their existing PPO plans. Most of the primary care physicians in these PPO plans are employed by these health systems. Our employers have found oftentimes that access to primary care through these models often increases spend because of the referral to the mothership, if you will. That has to stop. This has to be a patient-centered, outcome-focused type of activity. And not sure that you can do that in a fee-for-service model as it's currently designed. Does that help?
It does, and you actually started answering my next question I wanted to ask, which is, what is the biggest challenge that you feel like you are working to alleviate? Is it getting employers to understand? But you answered that through, is it about educating them, or really just listening to what their pain points are and going in there with some solutions? But with what you were just saying, do you then? I mean, I have limited understanding of this, so I'm learning. But do you then feel like these employers promoting is it the problem to solve? Is it that employers should promote the HMO plans more in order to make this a better system, right? Like cost wise, and then obviously access to their primary care provider too. It's almost like there's logistical tactical changes, but also a cultural change perhaps as well,
Yeah.
to get
Yeah.
people right to go to their primary care provider as their first stop versus getting referred to all the different specialists.
An excellent point. Um, the, you mentioned HMOs, and what we're talking about here is not an HMO. Employers, at least our employers, larger employers, um, the HMOs are not in favor. Now, narrow networks can be, uh, that can be set. Um, there are a number of things that can be done. Um, I'll give you an example. I mentioned I was the executive director of Texas Employers for Affordable Healthcare. In the last legislative session, we were successful in getting House Bill 711 passed. That essentially eliminates anti-competitive language in contracts between hospitals and health plans. Employers are not quite yet aware of this. Um, there are three things that are most important with its passage. It eliminates gag clauses, which one of those is access to your own data to understand. Employers don't have readily available access to their data. That is still a hurdle. We don't have the time to address it right now. We're focusing on getting the APCD funded in the next legislative session. That will help a bit, but access to data. But more immediate, what can be done is employers now can tier and steer to value. Those contracts in the past provided against tiering and steering to value. One would say we want to tier towards your highest providers, that we want to a tier towards our providers and primary care as well as specialists. And that was not allowed in these contracts. That is now prohibited. We hope that is one model. Another is, again, I mentioned most of our members have PPO plans. I think for this to work, there has to be a lot more direct contracting. Employers are more open to direct contracting with providers. We hope primary care physicians are more open to direct contracting. Um, the contracts that we set up through our smart network were all direct contracting outside of the existing PPO plan. So that is another option. Um, what I think is going to be most helpful, and as we get more data through these common measure sets, where we're looking at total cost of care, where we're looking at more of these value-based, one-sided, and then hopefully two-sided risk adjustments, employers will be more likely to adopt primary care as this foundation. My board chair is an example. Hey, we believe in this, but I can't find anything in the literature that really shows that having a primary care foundation hub reduces total cost of care. They want to see total cost of care. And by inference, by using some of these common measure sets, by looking at effective referrals, you'll get that. But that is the biggest challenge right now is getting employers on board and demonstrating to them that there is a true ROI here. These are not, these employers did not ask, and they're all, our employers are self-funded. They're spending hundreds of millions. They have small healthcare companies. That's what they are. They didn't ask for this. They don't want it. Why should we be responsible for fixing it? Why can't the delivery system fix it? And we'll just take advantage of it. And quite frankly, I think when one looks at this, there's so much opportunity out there, but the employer really needs to look in the mirror and say, are we doing all that we can? The opportunities are out there. There's wonderful advanced primary care groups that are out there. Most of these are through a direct contracting option. So the data is coming in as we speak. We just need those case studies to show that they work, that they truly work. The one thing I think is most important in this model is that the primary care serves as a navigator for a needlessly, but by design, complex healthcare delivery system. I think the RVUs, of course, you'll love to hear this. We need a larger RVU for primary care. If they're fully functioning at the top of their license and not just acting as a referral mechanism to the mothership, if they are truly delivering the value that they're capable of, and they're often not even allowed to, they're incentivized when employed by these systems for less than ideal optimization of their practice. If we can just get physicians, they want to practice at the top of their license to be able to do this, I think we'll be well on their way. How do we change the RVU from 1 to 3 or 4? Well, I don't know what it is, but it's not 1. And that's more than my pay grade and opportunity to, we can't fix that as employers, but there's so much promise in primary care um, that I think employers partnering and working side by side with primary care groups in a new model using some of the tenets that I described to you, I think creates great promise and hope for the future.
It's it's so fascinating to hear because I love that, yeah, innovation is really being driven by employers, and it kind of reminds me of how the idea of health insurance even started, right? Didn't it start at Toyota? The idea of giving employer sponsored health insurance. Chris, this has been
Started in
super
Texas, by
helpful.
the way, at Baylor. You know that
Oh, right.
in the 1930s
Yeah.
with at Baylor University in Waco is where health insurance was uh, was founded, and
Wow.
that was for the hospitals,
Okay.
and then later for the physicians. But it has its roots in Texas.
How cool. So yeah, this is where then we need to keep innovating is in Texas. We're the home of
Yeah,
innovation. This has been super helpful though, but I do want to ask you one more question, which is
sure.
if and the way I preface this is if you had a magic wand, right? If we could change one thing about primary care just with the flick of a wand, we could wake up tomorrow and this one thing could be changed, reduced, whatever it is. What would that one thing be? I think I have a feeling of what you're going to talk about, but what is that one kind of key change that would need to happen in order to really lead to high quality primary care?
Mentioned it to put effort to have the data, the case study to show the true value of primary care. It's not there now, and it can't be if primary care is in a silo outside the rest of the delivery system. It's not good enough to refer to in-network specialists. It's not good enough to say, go see who's in your behavioral health network. It's not good enough to spend 15 minutes with a patient. Um, the magic wand would be um, to see fully integrated, care coordinated primary care and not just standalone primary care shops. I don't know how we get there, but we are getting there.
Yeah, I mean, it's really through conversations like these, I think that just first, I think educating, right? Really educating people on everybody knows that healthcare is expensive. It's inaccessible. Unfortunately, health outcomes are getting worse. And so there are these solutions that we can employ. And I think, as you said, really leaning into the case studies of showcasing the value add of primary care. I know that's a big thing here at the consortium that we want to constantly also be doing it. It's why we started these monthly Mondays as well, to really keep primary care at the center of the conversation and to keep showcasing its value. So thank you, Chris, for that amazing, amazing interview. I know I learned a ton. If you have any questions for Chris, please feel free to reach out to him. And if you have any feedback for us, please let us know. If you have any ideas for future guest speakers, we would love to hear from you. This is Texas Primary Care Consortium's Monthly Monday Primary Care Talks. We'll see you next month.